Assalamu alaikum and good afternoon to everyone joining the 12th CBEC on the Web event. This event is slightly different from our previous 11 CBEC on the Web webinars, in the sense that not only do we have a web presence of many distinguished participants, we also have a room full of physically attending participants. So if the main room in the CBEC could actually open their video, as you can see, the room has a few people appropriately distanced. So this webinar, which is entitled Public Health Challenges of COVID-19, Vaccines and Beyond, is occurring at the culmination of a 3-day hybrid workshop that our center was conducting. This is the first hybrid workshop that we have conducted. This is the third and last day, and the hybrid workshop was on ethics during public health emergencies. So we had a total of 26 participants actively participating, half on the web and half in the room that you see in front of you. But for this particular webinar, we have opened this up for a larger population on the web, so that more people can tune in and understand the discussions that have been going on. The seminar has actually been talking about all the aspects that will be covered and brought into a 1.5 to 2 hour segment right now. So I would like to welcome everyone on behalf of the Center of Biomedical Ethics and Culture, SIUT in Karachi, and the CBEC Kemri Bioethics Training Initiative, which is a collaborating partner in this event that we are doing in this workshop. So we have, the idea today is to sum up cover a lot of ethical issues that have been discussed, are being discussed world over in the past several months, and every few weeks there's another emerging problem that comes up. Similarities between Pakistan and Kenya and the rest of Africa and the rest of the developing world, the lower middle income countries, is striking. So while in some places, in some aspects, we've been a little better, but in others we lag behind. But our problems and our challenges are the same, which is why we have a very good distinguished panel of speakers being led by Professor Walter Jaoko. And I will introduce all our panelists, and then I'll introduce some of the housekeeping rules. But first, some introductions. Professor Walter Jaoko is a physician and a professor of medical microbiology and tropical medicine at the University of Nairobi in Kenya. He is the director of the Kavi Institute of Clinical Research, also at the same university. And since 2017, he has been an extraordinary professor of medicine at Stellenbosch University and the Center of Bioethics and Law in the Department of Medicine. The Center of Bioethics and Law is another collaborating center of bioethics for WHO, as is our center, CBEC. Professor Jaoko holds a bachelor's degree in medicine and a PhD in medical microbiology from the University of Nairobi, and a master's degree in tropical medicine from Liverpool University, and a postgraduate diploma in health research ethics from Stellenbosch. He has close to 200 peer-reviewed journal articles, which is phenomenal, and has been a member of a number of ethical review committees and other review boards. So he will be starting today's deliberations with a general talk, followed by a commentary by the next speaker, brief commentary by Professor Vincent Muruti Kiwe. Vincent is a medical doctor working within the Clinical Development Department at the International AIDS Vaccine Initiative. He is responsible for protocol design and safety monitoring of clinical trials, evaluation of biomedical interventions against HIV, including vaccine candidates. Vincent has a 10-year experience of vaccine development and clinical trials. So therefore, he is very well suited for today's workshop. He has been working in the East African region for a long while in various capacities in the government sector as well. He received his bachelor's degree in medicine from the University of Nairobi, and a diploma in tropical medicine and hygiene from the London School of Hygiene and Tropical Medicine. And then a Master of Science in Vaccinology and Pharmaceutical Clinical Development from Italy. So he will be commenting on Professor Jaoko's talk that will set the stage for today's webinar. We have 4 discussants today who will be giving brief interventions. One of them is known to us for the workshop participants who have been with us for the past 3 days. That's Natasha Anwar. Dr. Natasha is a consultant molecular pathologist at the Ahad University Hospital in Lahore lab. And she's also an associate faculty of the Center of Biomedical Ethics and Culture, CBEC, over here in Karachi. And she's an alumnus of the CBEC programs and the diploma program, as well as the master's program. The other discussant, another alumnus from our program, Ms. Melba Kitindi, is an advocate of the High Court of Kenya for the past 13 years. She is a founder and manager of Kitindi and Company Advocates. She has obtained her postgraduate diploma in biomedical ethics from CBEC very recently, and she chairs the Kenya Medical Research Institute's Scientific Ethical Reviews Unit, KEMRI CIRU, in Nairobi, Kenya. She brings together beautifully the legal as well as the ethical aspects, along with the very forceful human rights angle to her deliberation. So she will be bringing all these aspects to today's talk. Then the final speaker is Dr. James Jaoko. Dr. Jaoko is a medical doctor who holds a master's in public health from the University of California in Berkeley and a PhD in epidemiology from Belgium. His area of interest has been his involvement in the optimizing HIV care and has been working at the Kenya Medical Research Institute, KEMRI, pursuing his goals. So these are the 4 discussants. So Dr. Walter will start, but before that, just a couple of rules. One is that please keep your mics muted, and you can certainly have your videos open, but your mics should be muted. And put your questions in the chat box in the Zoom, and also we are on Facebook Live. So please, if you're following us on Facebook Live, put your comments in the comments box. Dr. Saima Pervez Iqbal is going to be moderating the questions and answers, and she's compiling all these questions, which she'll put to the respective speakers for them to respond at the end of all interventions. So the first intervention is going to be setting the stage by Professor Walter Jaoko. Over to you, Professor Jaoko.
Okay, thank you so much, Prof. Amir, for this invitation to give this presentation. And it's always a pleasure to work with CBEC. So as has been mentioned, I'm going to talk about the public health challenges of COVID-19 and on the issues of vaccines and beyond. If you allow me, I'm going to put off my video just for more bandwidth. So the outline of my presentation will be, I'll give a little introduction, and then I will talk about COVID-19 public health measures that have been taken globally, and then I'll end up with the ethical issues on this public health matter. So now public health measures that have been implemented during this COVID-19 include lockdowns, mandatory quarantines, mass surveillance, and mandatory vaccinations. These measures usually bring a conflict between individual autonomy and public good, and sometimes appear to be very coercive. I'm going to focus on several. I'm going to focus on wearing of masks, closures, lockdown, surveillance, and vaccinations. Closures, we're talking about pubs, places of worship, schools, and so on. Let's start with the issues of the mandatory masks. So this is a picture just to show us, this is a picture that you see repeatedly globally, wherever you go, including the developing parts of the world like Kenya and Pakistan. Now, the issues around mandatory wearing of masks are several. One of those is liberty. It is considered an infringement of people's rights. It's associated with authoritarianism. If you recall, some parts of the US, in some states, they were demonstrating against wearing of masks. They felt that the governors were too authoritarian. But it's also associated with the issues of beneficence. People feel like that we don't have enough evidence regarding its benefits. And wherever there is some evidence, it's also very inconsistent. They argue that there have been a few studies that are showing these benefits, but we should also recognize that it is very difficult actually to conduct a study that would show the benefits of wearing masks. The gold standard for evidence is randomized controlled trials, but that is impossible to do with the wearing of masks. Then the other ethical issues of that of non-malfeasance, people have argued that wearing masks affects people psychologically, socially, and even physically. They've talked about what you call human social harms, and that it can even impair communications and connections. When people see each other's faces, the gestures that we have, the facial expressions are part of communication, and that is disrupted by the wearing of masks. And some people have also argued against the use of masks based on justice. The concern here is that the vulnerable people are most affected. So the deaf people, for example, who read lips, they are not able to communicate when everybody's wearing masks. And what about the poor people? It is argued that those wearing of masks has a cost that disproportionately affects the poor people, so that it is more seen like an intervention that is disproportional. And it's no wonder there have been all these demonstrations in different parts of the world saying, it's my body, it's my choice. I don't need to be forced to wear anything on my face. But then there have been counter-arguments to the issue of wearing of masks. Those who argue that it's important that we wear a mask because in a pandemic, even marginal gains are significant. So you don't need to wait for robust evidences. As long as there is some benefits of wearing masks, we should encourage everybody to wear masks. Others also argue on the strength of altruism, that by me wearing a mask, we are identifying with the human race for the self-preservation of mankind. And that when I wear a mask, actually, my wearing of a mask is to protect you. It's not so much for myself. And you're wearing your mask is to protect me. So this idea of you are doing it for others and not for self. And then what I've just mentioned, that that it is a reminder that we owe each other as human beings to survive as a human race. What about closures? With the COVID-19, this was what is common. You see, this is a sign of one of the popular amenities in the UK, in Toronto, that was closed because of COVID-19. Closures have also resulted in churches being closed, mosques being closed, and other places of worship. And And what are the ethical issues around closures? So people have argued that it is harmful. So based on the principle of non-malfeasance, human beings are social beings, so closures lead to psychological effects. Places of worship being closed results in people losing a spiritual connection. Emotional connection is lost when you close places of sports, so people cannot be able to exercise or enjoy themselves watching a match. So that has some emotional harm. It has also been argued against, based on the principle of autonomy, that confining people at home diminishes their liberty, removes their free will, and human beings are adults and they know what is best for them. So a government cannot come and tell them what to do. They're autonomous beings. And others have argued against closures from a human rights perspective, that you're interfering with the rights for free movement. and the rights of association. And others also look at it from a justice point of view, that the closures affects the poor more disproportionately. Their incomes are affected much more compared to people who are well-resourced. And so it's a survival tactic for the poor people to have to go out to fend for themselves and to fend for their families. And again, the issue of inequity, that closures disproportionately affects the poor more than it affects the rich. What about closure of schools? So this is an interesting ethical discussion. One is that children are largely unaffected by COVID-19. So of course we know that children become infected and some of them have even died, but proportionally they are very few compared to the others. So the reason why schools are closed primarily is to protect others, especially the elderly who are vulnerable. But it's also known that children are known to be important sources of viral spread of other viral diseases. So that has been extrapolated to COVID-19. But the ethics around it is that of non-malfeasance. Children kept at home have a higher risk of anxiety, depression, and even physical abuse. Then there have been people who have argued against closures based on the principles of beneficence. Does it really prevent transmission? And we can't really say for sure and to what proportion that does. And then the other ethical position is that of justice, because these closures of schools have affected immigrants and racial minorities more than the others, and also brings in the issues of inequity in the terms that there are some schools that have closed and going on virtually, whereas the schools that are attended by the poor are not able to do that because they do not have the resources to buy the things that go with virtual education. And then closures also has affected the parents because the poor families who have to then stay at home because the schools are closed, they do not have, they are not able to afford caregivers, people to take care of the children at home. And so some parents have had to lose their jobs or lose their income because of the closures of schools. What about lockdowns? This is a sign that you see, we are seeing largely, especially with the start of the pandemic. Now lockdowns, where people are restricted in only one region, not to go to another region because of the fear of spreading COVID-19, infringes on people's civil liberties. It affects the adults' autonomy by denying them the freedom to choose where to go, when to go to those places. There is also an argument based on non-malfeasance that lockdowns result in psychological harm. It affects people economically. Many people have lost their jobs or they've had salary cuts. It has also, in parts of the world, at least for Kenya, I know for sure, it has increased domestic and sexual abuse amongst the people, the boys and girls who are locked at home. And then it has also resulted in increased pregnancies among young girls. Again, the principle of justice, most of the people who are affected by lockdowns are the poor and the immigrants. What about surveillance? There are countries that have used surveillance during the COVID pandemic, and they largely used it for local locational technologies, whereby they were using it to track travel of people, also to track people who have been found to have COVID-19. The government would know exactly where they are, whether they've gone shopping, if they've been restricted, whether they've gone against the restrictions. And the way this was happening was that the infected people were tagged with an electronic device, which could trace their movements. And if they went out of the restricted areas, it would trigger an alarm and the government would know who has broken the curfews or the restrictions that have been imposed. The problem that we have with this, for it to work, you need centralized data, and the government was working with the phone companies to be able to track and trace where people are. The ethical issues around surveillance are largely two. One is that of autonomy, that people's consent were not obtained. Once you're infected, your data is used to trace you. to be able to see if you're breaking the lockdown restrictions. The other one is privacy. The question is, once you get this data, who knows who will have access to it and what it will be used for beyond the COVID-19 restrictions. What about COVID-19 vaccines? Now, the problem around this, in some countries, this is a picture of Kenya where at one time the president ordered cabinet to be vaccinated. The whole idea behind this was so that it was a time when people were very hesitant to get COVID-19 vaccination. And there was a discussion that if the politicians and the leaders were vaccinated in public, it would bump up people who are going for COVID-19 vaccination. So the idea itself was good, but then the president ordered that cabinet ministers should take the COVID-19 vaccine. It became a directive. So one of the issues is that of autonomy, as we are going to see shortly. The other issue was when the civil servants were not taking the vaccines, the head of the civil service ordered that it would be mandatory for civil servants, and a date was given that by a particular date, if they had not been vaccinated as a civil servant, disciplinary measures would be taken against them, and it included salaries being stopped. Now that lest you think that that is only for developing countries. There is in Australia, Western Australia, there was an order that people who are working in certain facilities needed to be vaccinated by the 1st of October. And they said it was a legal requirement. If you did not have the vaccination, you would be fined, and then you'd also not be allowed to go to work. In the US, the US Army, the Pentagon required that people be vaccinated. And that was constituting about 1.3 million of the US soldiers. And this was to include all active duty military staff. And all the US government was arguing that this is just in addition to the other vaccines that are mandatory for the US servicemen. So they get yellow fever, mandatory. They get, I think, meningitis, mandatory. So this was just, the US government did not see why this was an issue by just adding COVID-19 vaccination. Now, these issues of vaccination it was a legal obligation to be vaccinated. It's distinct from an ethical obligation, since the latter is not enforced by threats of restrictions in the case of non-compliance. So this, the law in the House will be distinguishing between the legal and the ethical. Now, the ethical issues around vaccinations are, of mandatory vaccination, revolve around non-malfeasance, for example, the potential of harm from the vaccines. And if you force people to get the COVID-19 vaccines and they get harmed, who is going to pay for that? Who is going to compensate them for the harm that is caused? Remember, all these vaccines are currently under what you call emergency use authorization without a clause for payment for people who are harmed. Mandatory vaccination also interferes with the freedom to choose. It interferes with the human rights, so both autonomy and human rights, freedom to choose and the right to choose what they want and what they should get. It also, on the other hand, the people who have been supportive of mandatory vaccinations have a different argument. In the case of Kenya, there are some ethicists who are arguing, for example, that when you make it mandatory for the civil servants to be vaccinated, civil servants should actually be willing to reciprocate the favor that the government has given to them. And the argument was like this, that during the COVID-19 outbreak, whereas many companies laid off their workers, reduced their salaries, the government continued to pay people even when they remained at home doing social distancing. It did not reduce their salaries. And so this was just time for them to also reciprocate the requirement for vaccination that the government wanted. There are people, of course, who have argued from a public health perspective that being forced to be vaccinated has a greater good because it benefits the public. It's a public health control measure. So we shouldn't look at individual autonomy, but look at the greater good. Now, the question then we need to discuss is to mandate or not to mandate in terms of giving the vaccines. Now, we know that vaccines are the most effective public health tool. Governments may mandate it in order to protect well-being of individuals or communities by using the Public Health Act. And the governments have argued that it is not the first public health measure that is being made mandatory. We know, for example, when you have multi-drug resistant TB, you are forced to be treated. And the idea behind that is for the public good. The other side, however, is that mandatory vaccination interferes with individual liberty. And therefore, we need to create a balance between communal well-being vis-a-vis individual liberty. So we must therefore carefully evaluate and discuss mandatory vaccination if at all it is going to be implemented. And the questions we need to ask ourselves if we're going to make it mandatory is one, the measure that is going to be taken in the name of public health measures is one, is it necessary? It should be considered necessary with regard to vaccination if it creates a herd immunity, where if it is going to protect the most vulnerable population, and we know that it does, and if it is going to protect the capacity of the healthcare system to deal with the large number of COVID-19 patients who are occupying beds, preventing other people with other illnesses like diabetes or road traffic accidents to be treated. So the question, is it necessary? And we say yes. For COVID-19 vaccine, we know that it is necessary. Will it significantly reduce risk of sickness and death? That is the other thing to ask yourself. And if the answer is no, we say that if the answer is no, if public health goal can be achieved with less coercive interventions, e.g. public education, then it is unethical to enforce it if there are other ways that you can do it. The other question is it proportionate? And for the COVID vaccine, we say yes. We then need to communicate the reasons to the affected communities. We need to implement mandate, but accommodate reasonable concerns of the community. So we should not use excessive force. And liberties should not be challenged for longer than necessary. So if you're going to remove individual liberties for any intervention that is going to be made mandatory, we should ensure that it is only for the duration of time that is absolutely necessary. And what we need to therefore frequently reevaluate to ensure that the measures remain necessary and proportionate to achieve the public health goals. So if you're making an intervention mandatory, it shouldn't be for life. It should be for the duration that is required. And therefore you need to keep on evaluating to see whether it is necessary. And so this is a cartoon just trying to kill a fly with a hammer. That is disproportionate. The other question with regard to vaccine, is the supply sufficient? Any public health measure that is going to be made mandatory, you need to answer the question of supply. And supply should be sufficient, reliable, reasonable, and people should have a free access to it if you're going to make it mandatory. Otherwise, the mandate will be ineffective, it will be unduly burdensome, and it will be unfair, and it will also exacerbate social equity. And we've seen that with the vaccine. So if you make COVID-19 vaccine mandatory and it is not available, then it is not ethical. The other question, is the vaccine safe? When risks associated with vaccines outweigh the risk of harm without the vaccine, we cannot ethically justify making it mandatory. Then the coercive exposure to harmful product, I've already talked about this earlier, would violate ethical obligations to protect the public from unnecessary harm. So if you're making it mandatory and it has some harmful effects that are disproportionate, then it cannot be ethical. And the other question is, who is going to compensate people who are harmed in the event that you make vaccination mandatory? Then is the vaccine effective? The other question you ask yourself, will it reduce transmission of infection? Will it prevent hospitalization, which is the main aim of COVID-19 vaccination? Will it protect the capacity of the acute healthcare system? as we've talked about earlier. It would be unethical to make vaccines compulsory if that vaccine is ineffective and is not able to achieve the above. And finally, will it affect public trust? We should always remember that governments work with the public. And if forcing vaccination will erode the public confidence and trust that we have, will it affect uptake and adherence to other public health measures? So once the population gets the impression that they do not trust the government because of forcing vaccination programs on them, will that affect other measures that we talked about earlier, like social distancing, washing of hands, and so on and so forth? And in effect, it might even create more vaccine hesitancies and may even be seen to be oppressing the vulnerable. So in summary, what we've said, we've looked at the harms of pandemic, not just the virus, but also the other measures that were taken to prevent its spread. We've talked about lockdowns, and we've talked about the wearing of masks and the surveillance and so on. Public health measures create a tension between the needs of the whole population vis-a-vis the rights of the individual, and with the needs of the whole population is always often referred to as a greater good. The problem is that liberal democracy respects individual liberty, and even if we don't agree with what people's choices are, liberal democracies would say, let the people choose what they want to do. So when you enforce people, you're interfering with their liberty. Now, mandatory measures have both ethical issues and must be implemented cautiously, as we've talked about. I just want to acknowledge some of the references that I got in the WHO policy brief titled COVID-19 and Mandatory Vaccination, Ethical Consideration, Caveats. I'll stop there and just thank all the healthcare workers working day and night to keep us safe during this global pandemic. Thank you very much.
Thank you, Dr. Jaoko, for a fantastic summary of the vast array of ethical issues that have crept up during the pandemic. I think you've done an excellent job in setting the stage. These are some of the issues that we have been discussing over the past 3 days during our workshop over here in Karachi and on the web. Now I'd like to invite Dr. Vincent to make a commentary on Dr. Jaoko's deliberations. Dr. Vincent, over to you, sir.
Thank you very much, Professor Amer. And thank you, Professor Jaoko, for setting the stage. I think you've made it very clear that indeed there are very many measures that have been put in place as public health interventions to ensure that we could safeguard the population, maintain our social systems, and indeed most of these measures have been put in place by governments for the common good, or as you put it, for the greater good. You have highlighted also that there has been a conflict between the needs of individuals and their individual autonomy, as well as the need to maintain the greater good. And the question that has brought this tension is, can we justify infringing on people's rights and taking away their autonomy in order to maintain the public good to the extent that we have done for this particular pandemic? I think Professor Jaoko also did a good job in highlighting the fact that many of these interventions have also carried with them some forms of either social or individual harms to members of the population. So these have ranged from economic harms caused by lockdowns and closures of businesses and institutions, psychological effects of these closures. And I thought that Prof. Jaoko made a very good point on pointing out harms to school-going children who were being kept out of school, not for their own protection, but for protection of other individuals. And so that really does bring a question as to whether this could be justified. There have also been effects of the lockdowns and social harms associated with that, including interpersonal violence, as Professor Jaoko stated, and also the risks to loss of privacy with use of surveillance apps that have been used for contact tracing. With all these and taking all this into account, the question now comes, can we justify all the interventions that have been put in place? And indeed, have we met the bar? Does the effect of the pandemic actually meet the bar for interventions that have these wide-ranging individual and social effects? Going specifically to the issue of mandates, I think whether we are talking about mask mandates or vaccination mandates or mandates for curfews, as has been instituted in Kenya until just this week, we have to have a clear threshold and justification for this. And there also needs to be an equitable distribution of these interventions, as Professor Jaoko has said. One of the main issues I think that has arisen over the past year and has been quite prominent in Kenya is the lack of communication, clear communication to members of the population about what the risks that are being addressed are and what the benefits of these interventions are vis-a-vis those risks. When talking about closures of businesses, Professor Jaoko highlighted the fact that these closures have disproportionately affected members of lower socioeconomic classes and seemed to spare those from higher socioeconomic groups. And the question from members of the population naturally would be, why are these interventions being targeted towards us? And these might be seen as mainly communication challenges. When looking closer at those interventions, we've also seen a failure in many countries to try and address the harms that might come with these interventions. So if you prevent people from working, if you prevent people from carrying out business activities that earn them a livelihood, are you going to then provide some form of compensation? I think in some countries, they've done better than others. A good example is in Uganda, where public transport was banned completely. But the government tried to make up for this by delivering food and offering it for free to areas where individuals would be hardest hit by these types of lockdowns. And I think these are the types of interventions that might help these mandates to be more acceptable to members of the general population. When looking at vaccine mandates, the general message that we have been sending, and I think Professor Jaoko reiterated this, was everyone who can get vaccinated should get vaccinated, because by doing so, they protect themselves and they protect others, thus bringing an alignment between self-interest as well as obligations that we have to other members of the population. This has generally followed the theme that individuals who are in a community should do what they can to secure the needs of that community. I tend to agree with this general principle, but I do think that in putting in place these mandates, the justifications for enforcement or cooperation, for example, in Kenya with regard to members of the civil service, the justification needs to be brought up front so that individuals feel that they're performing a civic duty or are actually helping themselves, rather than being forced into a situation where they are receiving a medical product or even a medical procedure, some might perceive it, against their will. And just to touch on that a little more, there have been a lot of individuals who have gone to the extent of countering vaccine mandates and stating that these amount to forced medical procedures. When looking at it, and I hope that Ms. Katindi will comment on it, it is more of a legal requirement that to be in certain settings or in certain roles, perhaps as in a job or to carry out a certain task, one must be vaccinated. And the same has been done for mask mandates. And so the thinking is you're not being forced to get the procedure or to carry out the or to wear a mask, for example. You're just being told that if you are going to participate in certain aspects of society, you need to get that. And if you don't wish to do that, then you would be free to exclude yourself from participating in those activities. This brings a lot of tension as to whether people should be, whether this is a form of coercion and whether people should be forced to do this in this way. Again, going back to the need to get buy-in from individuals who are members of a general community, I think communicating individual rights alongside the needs of the greater society so that individuals can weigh out the risks and benefits would help to offset this tension. So I'll just conclude by saying that I do agree with Professor Jaoko's assessment that the majority of the interventions that have been put in place so far have been done with the aim of safeguarding our society to help ensure that we do not have health crisis that overwhelms our health system, that our social systems can be preserved as much as possible, and that the economies of our countries can continue to progress. I do think that as these mandates are rolled out, rather than having an approach that seems coercive or as a form of use of force by government power, they should be carried out in a way that they address the buy-in from communities by looking into what individual and community concerns are with these mandates and addressing them as they are implemented. These mandates must be based on demonstrable public health needs, as Professor Jaoko has stated, and should not discriminate against any particular groups or specific individual. And overall, I believe if members of the society were able to clearly see that these were all about protecting public health and not punishing or being punitive to any members of society, we would get greater buy-in and have an opportunity to enforce a lot of public health interventions much more efficient. So thank you very much, Professor Amer. Back to you.
That was a fantastic commentary on Professor Jaoko's deliberations. I think you've also taken his thoughts forward and found it a very good basis for which our three discussants will look at three different aspects in these public health, this entire spectrum of public health challenges. So Natasha will be talking next, looking at specifically the social fallout of the public health measures, etc. So Natasha, over to you.
Thank you very much, Dr. Amer. Vincent, I'm just going to pick up from, something that was very strong in your commentary on the talk, which was about communication and how important it was to communicate with the public. And Dr. Vakar has actually just put in the chat as well that one thing that he found extremely difficult to navigate through was all this fake news and all these misunderstandings about COVID, and the fact that we had this huge infodemic and all of these ideas coming across about how it's how it's transmitted, what sort of treatments work, what sort of treatments don't work. So I think all in all, I just feel that part of the challenge of communicating was that because this was something completely new, because we were still trying to understand it as scientists, that's where we had a bit of a lag in that communication, and that it created a bit of a gap. But instead of actually reducing that gap, and instead of trying to keep the public involved in every single new development that was taking place, as our understanding was getting better and better, that gap sort of widened, and that gap was then filled with all this sort of misinterpretation, and then everyone became an epidemiologist, everyone became an infectious diseases expert. So I think that again sort of just exacerbated the problem in terms of communication. There were lots of mixed messages in Pakistan. Definitely, we had lots and lots of mixed messages coming through. We had, on the one hand, we had health experts communicating the importance of wearing masks, and on the other hand, people in very prominent positions, I'm not going to name who it was, but I think you all know who it was, not deciding not to wear masks. So again, leading by example, we really didn't see that happen much, unfortunately. And when we talk about the greater good, somebody, obviously policymakers and people sitting in committees and making these decisions for the whole nation, they are the ones who are actually defining and deciding on on the common good, everything that needs to be done in order to protect every single person in the nation. But again, it was really, really clear that this wasn't being communicated effectively enough to everybody, how important it was to sort of, wear those masks, how important it was to, although difficult in our setting, and I'm sure in Kenya and other parts of Africa too, very difficult to actually try and maintain that physical distance because families live very close together. So I think that was again, a huge issue for us here in Pakistan. Something that I wanted to go back to was the fallout of this surveillance and the social stigma that this created for a lot of people, especially early on in the pandemic. So early on, we had huge police escorts standing outside homes of COVID positive individuals. And initially there was this program where if you were tested positive, you would then be taken off to a government facility. And that government facility was normally a government hospital where you would be quarantined. And that scared an enormous number of people because all they saw happening in the news was somebody being put into a car and being taken away somewhere without, just being allowed to grab a few things, maybe a phone, if that. And all of this happening, with a police escort. And a lot of media attention. I think the role of the media in this entire pandemic, I think you could probably do a webinar on that in itself to just evaluate how irresponsible some media channels were in, showing faces, putting up data of, very sensitive data, showing people's addresses, their CNIC numbers, their COVID positive or negative status. So I think all in all, all of these things contributed to a level of mistrust. And I think that also kind of stopped people, and people weren't as willing to be tested, especially if they didn't have very, very strong symptoms. People were scared initially in the first wave in Pakistan to actually come forward for testing. It had become such a terrible stigma to even sort of, know anybody, or if your neighbor was COVID positive. And so, it created a huge social stigma. And I think that sort of leads me into the next part, which is the surveillance and the kind of information that's been collected from this entire pandemic over the last 18 months. We've got a huge COVID database, and this database contains a lot of information from lots, tens of thousands of people, their addresses, their CNIC numbers, their very, very private information, sensitive information. And how is that being protected? Where is that being stored? When will they stop? Will they stop collecting this once the pandemic is over? What will they do with this database? A similar database was created during the 2011 dengue outbreak in Punjab, which is still continuing till today, but every year the data is upgraded and we only get to see the current year's cases, but we don't know, we're not informed about what happened about the previous set of data. So again, the level of transparency, which contributes to developing trust, is not there. We started off in this pandemic really hailing the healthcare workers as heroes. And we even had an amazing song that was written about all these healthcare workers. And after a very, very long time, we witnessed in Pakistan that healthcare workers were actually respected and, and honored And everyone was really, really grateful for what they were doing, which was on the front line, taking care of very sick patients, risking their own lives before the vaccines came out. And we haven't really, and I've seen a real shift in the last, in the last sort of 6 months. I've seen we could say that this is just fatigue. Now, it's people are now tired of not being able to access the regular healthcare that they need. We can maybe think that this is just some other, something else is happening here. We've got people getting more and more angry and frustrated with healthcare workers now. And I think it's really sad. I think it's really sad that what's happened, people are exhausted from this pandemic, and we don't seem to have any end in sight other than relaxing lockdowns, other than relaxing the requirement to wear masks if you're outdoors. But alongside that, you see, because you're being bombarded with, again, other new requirements. So now the vaccine. So vaccine mandates. Again, in Kenya as well as Pakistan, we had again a mandate from the government for certain groups of people to be vaccinated. They must be vaccinated. Civil servants, for us as well. And yes, exactly the same thing happened, that if you are not going to get vaccinated, we're going to stop the salaries. And we saw over one weekend, we actually saw a huge influx of people wanting to get vaccinated, and queues of people outside vaccination centers. And the other reason was because the government said we would stop we would block the SIM cards of mobile phones if for anyone who was not vaccinated. Now that was a potential, I think that was more of a threat than an actual doing it, but still it really made people get to those vaccination centers. So again, the level of coercion, I mean, I think, Vincent, you said that, it would be really nice if those measures would be a little less, a gentle shove in the right direction, as opposed to, pushing them into that chair and jabbing them with the vaccine. I think that that's, again, something that's really kind of worrying people. And when we talk about mandates, mandates are not really pulling somebody down into that chair and sort of sticking the vaccine in them, but it's forcing them in other ways. So if you are not going to, you won't be allowed to have fuel. You can't get fuel, you can't travel, you can't do many things. So step by step, I think those measures are becoming more and more pushes as opposed to gentle shoves. And again, the lack of effort in trying to explain why a vaccine is important. So if you are going to continue to implement these coercive measures, you're distancing yourself from the public. You're actually creating more, more reasons for them not to trust you, and more reasons, like you said, Vincent, for not to be, to not then trust any other public health measures that are implemented. We've struggled for years with polio vaccination. We've struggled with our healthcare workers being killed because people don't trust the vaccine that's being given to their children. So for us, it was even more important to be careful about how we roll out the COVID vaccine. So, I mean, I'm going to just maybe end there and ask Melba to sort of comment and continue.
Actually, Natasha, thank you very much. You've elaborated very well on the social aspects. The dimensions of the problems that have come up, the challenges, have been multifaceted. And this is a good summing up of all the various dimensions. And while we want to move to the legal aspect, before that, I would want the deliberations by Dr. James Jaoko on the aspects of the public health impact of and the imperatives of the various measures taken. So, Dr. James.
So I'll very briefly just discuss the public health aspects in brief, and just try to give it that perspective to align our session to the challenges that we are facing.
So
as I
James,
go
can
into
you
this,
just put your screen on your slides on slideshow so that they are larger? Thanks. Perfect.
yes, sorry about that. So I think my attention is drawn to the fact that we've had like four measures that are recommended, hand washing, keeping social distance, putting on of masks, as well as vaccines. But I believe that you've all noticed that the ones that have caused a lot of heat are the last two, which are the masking and the vaccine. And it's something inherent about almost invading personal space. And what is it in me that do I have the space to make a decision around myself? As Professor Jaoko was saying, a mask can interfere with communication, human interaction. I may not feel good. It blocks my breathing. I feel, I end up getting headaches and things like that. And vaccines, are they really safe? How come they've come out this fast? Yet we've had diseases that have been there for very long and vaccines have not been developed for them. So these are some of the challenges. So I wanted to just use the slides just to focus my thoughts as I take you through reflections on the public health perspective. And when we are looking at what we are dealing with COVID and the vaccine and the directions that are recommended. By way of definition, and we've retained this definition for years now because it has worked well for us, that public health is the art and science of preventing disease and prolonging life and promoting health through the organized effort of society. And in essence, to just bring this into focus is that our outcomes of certain conditions are, the individual has a role to play, but it has to be a collective uptake of an intervention that makes a difference for certain conditions that are considered of public health importance. So that, for instance, at this point, I'll just be focusing on some examples in the past as we focus on what we are facing and what we'll face in the future to draw relevance. That one, a condition like multi-drug resistant TB, you will see that there's a direct implication of the individual's decision to the general public health in terms of health outcomes. Who ends up getting infected, as well as who ends up getting, to lose their lives because of a decision that someone with the disease made. And so our concerns from a public health angle is that, an individual can act as a propagating agent for an adverse outcome to the larger society. And so that's a problem. And it is on this basis that we design interventions to prevent disease and promote health, while issuing guidance and recommendations around how to deal with certain conditions. So at this point, I just want to take us back to the 90s in this, to just look at some data here very quickly to try and make a point on individual versus community decisions. So this is in Missouri in the US. This data is drawn from November, I believe, of 91, where the water system was flushed. And after a few days, there were cases of mortality from bloody diarrhea. And so the y-axis shows you the number of deaths and the x-axis shows the date. But the Department of Health, once they realized this, they ordered that individuals should now boil their water to control the disease. Looking at the data, a few days surveillance data of bloody diarrhea as well as deaths, that was following the 18th of December when that boil water order was given, showed that yes, there might have been some decline, but there were still deaths that were occurring. And so the reasons that were identified for this was that people did not believe that boiling water would make a difference. Granted that some, ended up taking up the intervention. So there might have been some reduction, but not complete reduction. And so the Department of Health had to make a decision for the community, and that was adding chlorine to the water. And at 27th of December, the outbreak was contained. So just to show that there's a place the individual plays, and there's a place where a collective decision might be made for us. So that at this point, I would just pose and challenge everyone that in the event that there was something that would be sprayed in the air, and we would be free from COVID, it's probable that if the departments of health would determine that whatever it is that is sprayed is safe, they would just do it for us, and we'll be free from COVID. Because when it goes into the personal space about an injection going into my arm, or I have to put on a mask, it's invading some private space. But essentially, public health interventions are guided by two principles, and that I believe has been talked about quite a bit, and Professor Jaoko also mentioned it, as well as Vincent. The herd immunity is a big discussion and a guiding principle in containing conditions. That is one. And secondly, is the principle of least restrictive alternative and how we apply it. But these are anchored on harm prevention and fairness. So one is in describing herd immunity, also known as herd protection and community protection, is that we're trying to create a situation where we have adequate number of people that are immune to a disease in a community. And therefore, those who are not vaccinated are indirectly protected because of the high immunization rates that block disease from transmission to them. And essentially, that is the discussion with the COVID vaccines. However, you will understand that the threshold of herd immunity is a function of two things: the infectiousness of the pathogen, which we denote as the R naught, as well as the effectiveness of the vaccine. And so the disease that is highly infectious, like measles, you want to achieve a herd immunity of about 95%. And if people stop receiving vaccination, like happened in 2018 and 19, there was a tripling in number of cases of measles in the developed world in Europe. So it's a concept that has to be guarded religiously if we are going to achieve it. And lastly, the principle of least restrictive alternative comes in when we ask the question that when you want to achieve herd immunity, how will you do it? And this principle implies that we need to apply least intrusion on personal rights and freedom as we aim at achieving high immunity. And so it's more of a balancing act, as every speaker has talked about. And the goal is to achieve the lowest risk of harm while heading towards herd immunity. And that is why we have an entire range of policies based on restrictiveness and the severity of the condition, whether it comes out as a campaign, and at the very end of the spectrum as outright compulsion. Thank you so much for your time.
Thank you very much, Vincent, for a very good overview from the public health perspectives of these problems. Now, much of the challenges have been the dimensions of the legal aspects of the pandemic and the individual lost in the public gaze and individual autonomy versus public good, etc. And coming from the legal aspects and also the human rights aspects, I think we will have some good, interesting comments now to be made by Melba. So Melba, can you please start.
Okay. I'll try and rush through the comments. I've picked quite a number of things from the speakers who have gone before me. I hope I'm audible.
Yes, you are.
Yes, so I mean, we are in agreement generally in line with the public health objectives and public health ethical principles that individual rights must sometimes, give priority to the common good. The difficulty posed by COVID-19 and other pandemics is usually to what extent can the individual right be limited? Is it a blanket limitation of rights, or is there some measures, some standards that need to be complied with? And this is where the law then comes in. The question is, to what extent can we limit, and what mechanism can we use to weigh, to see, to have an objective view of whether that limitation is then justified and meets the standards. So the first sort of guidance you have is that rights can only be limited to the extent that is permissible in law. So there has to be a mechanism within your legal framework in the country to permit limitation of those rights. Most countries rely on constitutional provisions, which then create mechanisms to enforce emergency powers. In the case of COVID, about 110 countries used the constitutional provisions to actually declare a state of emergency. So when the state of emergency is declared, then the country is able to enforce measures that can then limit individual rights. But those provisions in the Constitution always provide clear outlines that must be satisfied before you limit those individual rights. The other mechanism of the constitutional way is that it must pass Parliament. So there's some level of public participation that is envisioned when you invoke emergency rights. Now, the other mechanism that is used, which most countries used, is to forfeit the using the parliamentary approach, because it's cumbersome, it takes time, and people need to react fast in a pandemic. And in most circumstances, public health pandemics don't meet the threshold to declare a public health emergency within the constitutional framework. So most laws use the public health approaches. So you go to existing public health laws, and then you make rules, you make pronouncements through the ministry. So those are purely executive powers, which then limit stakeholder participation. And this is where we see COVID-19 laws coming to have an issue or bringing about the issue. There's no opportunity or sufficient mechanism for the public to engage in a conversation with government where executive mechanisms have been invoked. So another mechanism that is provided is both at international level, there is an attempt to kind of resolve and provide some guidance. When you have a law that limits individual rights, what should the law comply with? So the requirement is that, of course, it must be lawful, meaning that there must be a legal instrument that brings that limitation into force. The other requirement, as mentioned by the other speakers, is that it must be necessary to achieve a public health objective, and it must be proportionate. Prof. Jaoko also mentioned that it has to be time, it has to operate within a limited amount of time, and then it has to make use of the least intrusive and the least restrictive measures. So this means that when you're using law to coerce, to force people to comply with public health measures, it has to comply with those provisions. So I'd just like to ask some of you to think about the restrictions around COVID. Look at the restrictions of movement. Look at the restrictions of masks, of mandatory vaccination practices. Do they meet the threshold of necessity? Do they meet the threshold of proportionality? And are some of them causing disproportionate harm to a section of the society while purporting to protect, the public? So you'll find that when you think about most of them, they don't meet that threshold. When you look at, for example, restrictions of movement, closures of business, there's a section of society that is disproportionately affected, which is those people from lower income communities. If you look at issues of contact tracing, it brings about the issue of who has a legitimate interest in that information and how broad does that interest go? Do I need, is it a person I've come into contact with for 2 seconds? Is it a person that I've come into contact with a longer duration? Is it someone that I may come into contact with in the future, such as my workmates? Do they have a legitimate interest? So there is a delicate balance in trying to, create a logical, a rational, to prove necessity in terms of the measures that have been put in place. Another thing to consider when you're using the law to actually coerce compliance with public health measures is the use of law enforcement mechanisms. Both in Pakistan and in Kenya, we saw the police coming in to try and enforce these mechanisms. And in both situations, we see the type of the severity of the enforcement measures that were used. People were beaten. To some extent, people even died in Kenya because of the enforcement of public health measures by using law enforcement mechanisms. So we have to think about what does this do in terms of building trust to achieve public health objectives. When we force people, when we use law enforcement mechanisms, yes, it will kind of achieve an immediate compliance, but is that compliance sustainable enough to achieve the public health objective in the long run? And then more so, how does this interfere with public trust that is necessary for future compliance, future voluntary compliance of public health objectives? A lot has been said in terms of issues of human rights. So we have to think about the criteria that we've mentioned. Do the laws that limit human rights meet that criteria? Of course, legal measures in COVID-19 have also affected not only the users, but also the providers. A lot of issues have arisen that affect healthcare providers. Of course, one that has been discussed over is the issue of vaccines. We've even seen the issue of mandatory vaccines being litigated in court. There has been a court case in Texas that decided in favor of the use of that kind of mechanism, but the context was within a private institution. And in Kenya, we know we have employment laws, we have workplace safety laws. So the issue is, are you able to justify the necessity of obligating your employee to undergo mandatory vaccine? Is it linked directly to their work so that their dismissal would be justified? And even where the dismissal is justified in law, have you followed the correct procedure? So those have to be considered even when you're thinking about enforcing compulsory or mandatory vaccine provisions. Another issue that has raised concern amongst healthcare providers is, can a healthcare worker refuse to provide care in the context where the government has failed to provide the healthcare with the necessary PPEs? This is another legal challenge or a legal dilemma that comes in. How is the constitutional right of the healthcare worker to have a safe work environment balanced against the right of the patient to receive healthcare from that provider? And the general provision here is that where the healthcare worker has been provided with all the necessary PPEs, there is no reasonable excuse to refuse to attend to a person who's suspected of COVID-19 exposure or infection. But we know the realities on the ground is the government rarely is able to meet the obligation of safeguarding the work environment for the healthcare worker. Another issue I'd like to talk about is the issue of whether the law should be invoked to safeguard healthcare workers from legal liability arising from actions taken during COVID-19. We know right now we are hailing healthcare workers. They are the heroes. They have done all. When everything calms down and people begin to reflect on the impact of the services they received or did not receive during COVID, a lot of lawsuits are bound to come up. But there is a general use of the law. Legislators are now using the law to protect healthcare workers from any legal liability when it comes to actions that took place during that time. But then the question is it only healthcare workers that deserve this protection? There were other emergency providers that had to make quick decisions. There were other essential workers that had to compromise probably standards or efficiency because of COVID-19. Do they deserve this protection? Another consideration is, yes, we are protecting healthcare workers in the course of the work that they are doing, but will this protection extend to exposure outside of the workplace? You've gotten COVID-19 at work, your family or your friends are then exposed because of that, but the exposure is not within the workplace context. Should that liability then be extended to that? So there's a lot of issues, and I'd like to summarize just from reflecting on lessons. Coercive use of legal measures it's not a new phenomenon, but we have to take stock of lessons that we've learned from other pandemics. The most important lessons is that that laws and policies that promote and foster public health are those that are the least intrusive on rights. So if you look at laws that undermine rights, they are then also undermining the achievement of public health objectives. So we have to reflect on that. The other lesson is that the law alone is not sufficient. Yes, we've used the law. Yes, it has shown to be effective in managing public health perceptions, objectives, but the law alone cannot be sufficient, especially because the relationship within the public health sector is based on trust. And when we compel and force people into compliance, then we completely break the aspect of trust that is required for future voluntary compliance with non-epidemic public health interventions. So we have to think about that as we reflect on using the law as a public health sort of tool. Yeah.
Thank you.
Back to you.
Melba, thank you very much for your intervention. Before I open the floor for questions, and there have been several, I just wanted to make a comment. So you mentioned the physicians making difficult decisions, sometimes controversial decisions, like scarcity of resources and allocation of such resources to one individual versus the other during the time of COVID. And so while we were thinking ahead, and our pandemic had not actually hit Pakistan, and we had just a few cases, but we knew that we would be getting into the thick of things. The National Bioethics Committee of Pakistan deliberated the Healthcare Ethics Committee of the NBC, which is a subcommittee like the REC. So we and our center, we actually discussed the possibilities, and we came up with a set of guidelines, anticipating shortages, anticipating such decisions. And one of the clauses that we put in, without any legal consultation, it was just this is an ethical guideline. So the clause that we put in was that healthcare workers would be indemnified, would have protection for the decisions that they make because of scarcity of resources, etc. So this was left quite vague because, as you pointed out, should it only be limited to healthcare workers? How about others who are also involved in making critical decisions? And who is a healthcare worker? Is a nurse equal to a doctor or a paramedic or a ambulance driver, equal in that respect? So that was all left very vague because we were also weren't sure. But yes, we did build this into it. One question that was asked was, how do you have legal cover? So while we developed this for the government actually endorsed this. So we have the NCOC, which is the overarching body that has been controlling looking at the COVID management, and that they have a set of guidelines and published. So this was accepted and published on their in their notifications. So it was done so. So we thought ahead of that. The other thing was the frontline workers. And again, frontline workers can be a physician, nurse, operating room technician, anesthesiologist, anesthesia technician, ambulance driver, a receptionist, all of the persons who are in front lines. They would, if they contract the disease, they would be given preference in that hospital for facilities. So if we have been running out of beds, they would be provided a bed before anybody else, in order for us, the workforce, to remain confident. Not only that, our guidelines went one step ahead and said, physicians, so the frontline workers and their first degree relatives would be given the same protection. Because one of the fears, the greatest fears, that in fact, the study that our center is doing, Swalia is doing the study right now, one of the fears was that the physician or the doctor or the nurse or the paramedic would take the disease home to his grandparents or his mother or father. So if they fell ill, they would also have the first chance. I mean, they would break the queue, come to the top of the queue, and be admitted or give whatever treatment is required before anybody else, because we wanted to strengthen the front line. So these are things that we had actually thought ahead of time. So, and which is, I'm glad that you discussed them. So I think now I'll hand over to my colleague Saima, who is at the far end of this long table, and you can see a little blip. That's where she is. Maybe you can zoom in, Fareed, so that she is visible, and we'll be putting up questions for the various speakers. And if there is questions from the table, you can actually speak out and ask a question, which is the best way to do so. Fareed Sab, zoom in on that end so that Saima can start asking questions, putting the questions forward. Thank you. Sorry about that glitch. They were talking without the mic on.
Okay. I hope I'm visible. I'm audible.
Yes, visible and audible. Thank you.
Okay. So the first question goes out to Natasha and Melba. So the question is related to presentation of data in the newspapers and social media. So should there be, or is there any laws to make media accountable in a pandemic? Because there was a lot of misinformation going out. So,
Melba, could I just quickly, I'll let you comment on the legal aspects, if there are any, since the start of the pandemic, if Kenya has introduced any legislation about how the media report these, but in Pakistan, no, we don't have any legislation. And unfortunately, this is continuing because now we have a dengue outbreak in parts of Pakistan. And I think the way that, again, the data is being communicated is worrying. It's not to say that the public don't have a right to sort of have information about cases and what's happening in the country, but I think it should be done responsibly, and perhaps it should be done by somebody who knows, a little bit more and who's a little bit more informed, as opposed to a news channel reporter who perhaps is, not presenting it in the way that it needs to be presented, and perhaps creating more scare and concern. Melba, is there any legislation in Kenya?
So we have the Data Protection Act, which basically deals with data protection. I think Pakistan, you also have a bill, Natasha. It hasn't.
No, Melba, it hasn't come through. It's been formulated. The bill has been formulated. It hasn't been passed through the Parliament or Senate because we've still got commentary going on it. But it has a very small component on health data. You're right.
Yes. So in our context, we also have the Data Protection Act, which would impact health-related data. But you see, a lot of this has to do with individuals, who is the data processor and their obligations to the data owner. It doesn't reflect the bigger effect of the use, how the data is used and its impact within the community. So as data is being provided in terms of which areas of COVID are high risk, and there's a lot of stigma, there's a lot of profiling, which the law is then limited in terms of how it would address that, given the data protection is more individual responsibility rather than the obligation to the public or to the communities.
Okay, next question, Dr. Zaima is one of our live participants. Dr. Zaima, the floor is open to you for your question.
Thank you, Dr. Saima. First of all, thank you to all the panelists, very engaging presentations and talks. My question is for Ms. Melba. Melba, you spoke about coercing compliance. So I wanted to find out, in Pakistan, the general public's view about COVID was they were in a state of denial. They said that there's no COVID. So how does one deal with that? I mean, I'm not up for, hitting anyone or using force like that. But when the public, the mass community members feel that there's no COVID in specifically, so how does one go about that? Thank you.
So we had a similar case. I mean, our contexts are almost similar. So we had similar reactions and responses by our populations. In fact, now if you switch on the TV and look at a public rally, you'll hardly find anyone with a mask. And there'll be police there, there'll be politicians there, there'll be, all the policy makers who are involved in creating all these stand laws will be there. The main thing about public health interventions, and that's why I was talking about what we learn from history, is that you have to engage the community. There has to be information that is shared, that is relevant, that would make sense for the person to take personal and collective responsibility for their health. That's the only way. I think when we talk about developing countries, lower middle income countries, we kind of are still in the era of paternalism, where the government feels it can make decisions for its citizens because they wouldn't understand and they wouldn't comply anyway. But we are moving and evolving to the era of human rights and to the era of self-determination, even in the context of that. So even where we are dealing with collective or shared autonomy, which is our context, we have to think about our families, our societies, our cultures. We have to think about how can we as public health practitioners work with other stakeholders, particularly the community, to entrench responsibility, that sense of shared responsibility to take or be responsible for your own health. I think that's the main lesson that is being learned. Yes, the law will provide a tool to immediately achieve compliance. But remember, the achievement of public health objective is long-term. It's not short-term. So people will wear masks today because the policeman will arrest me. But immediately the policeman steps out, the mask is gone. So I think that's the message here. Yes, the law is a tool. It should only be a tool where we have explored all other options, including community engagement, to achieve compliance. Where we don't achieve compliance after all those efforts, then we can use coercive measures. And the main principle there is to build and maintain trust.
Okay, Dr. Asma wants to make. Okay.
Yeah, I just want to have a comment. In my opinion, this COVID episode let bear open our background, a very weak healthcare system, basically, our weak governance, our lack of education among the masses. And this all open up and build up the lack of trust, basically. So after this episode, now the COVID is now, inshallah, going down. We should focus on these aspects to gain the trust of our fellow humans and the masses. As Dr. Zaima is saying, that the masses are in a complete denial that there is no COVID, and it is true. So we need to increase the awareness, but we need to strive for building trust among our masses in order to move forward.
Thank you, Dr. Asma. I think that you've kind of brought us back to the first day, right? So you've brought us back to the very first day when Dr. Zafar Mirza was talking about universal healthcare, and we've come full circle. Thank you.
Yeah, definitely. Yeah.
So we have a question from Dr. Zafar.
Can I say something just to build up on what Natasha is saying, and the comment that has just come from the floor? I think we don't do enough to understand the circumstances that limit non-compliance by the public. So we've come from many generations of use of coercive measures, which has instilled that distrust in our communities. What efforts have we made as a way of understanding what is the root cause of this disbelief that is driven in the community? Why is community not trusting of interventions that are being provided for their own good? And in circumstances, it has to do with our context. We have to look at our culture, we have to look at the economic, our environment, but we have to do it in a scientific way so that it's able to generate information of what works and what does not work. And then we can create our own local solutions moving forward. We are always waiting for someone else to make the rules and for us to enforce at the time of the pandemic. Yet we can proactively generate this information and create our local solutions based on our context.
Is it okay to make a comment, Dr. Saima? Can I
Yes,
just?
please, Natasha, go on.
Melba, I think you're absolutely right. And I think that the issue being that, when you are, when we're looking to make that effort to engage with the community, to sort of try and understand why there is this level of mistrust. And it's stemmed from years and years of, lack of maybe effort on part of our public health and all of that. But it's the pandemic has highlighted our lack of preparedness as low middle income countries. And it's also highlighted how we need to be more independent. You said that, we're given solutions and we're asked to implement them. As far as the vaccine distribution is concerned, that again, we were left very much on our own. And I think the disproportionate allocation of vaccines across the globe, the fact that, people are now on their third doses in the US and in other European countries, and we still, have a significant population in Africa and in South Asia that has not been vaccinated, even with one dose. So I think that this idea that we need to become more self-sufficient in terms of planning and developing interventions, understanding our communities, understanding our people, how they behave, rather than just, again, adopting policies and interventions, as good as they may be in another context, really perhaps have failed us here this time round with this pandemic.
Okay, there's another question from Dr. Zafar.
Okay. I have a question to the panel. First of all, you are talking about the local culture and understanding our population. So when we look at the effective strategy for vaccination, the stopping of the SIM cards was an effective strategy. Would you agree? So our culture, then where does the human rights come in? Then we are defining, if it is an effective strategy, then we have to decide ourselves instead of going to the textbook and looking at what is the model. So our model then would be different. And as if I could say in Urdu, हमारे यहाँ डंडा चलता है. Okay. So then what are your comments on that?
Okay, can I ask Walter or Vincent to comment on this? Could you please unmute yourself? Yeah.
Yeah, so I didn't understand the statement in Urdu, but I assume that basically the question is around, with a situation where the government is trying to expand vaccination coverage, how is it justifiable to, for example, threaten to block people's SIM cards in order to push them to take it up? And I think when Natasha commented on this, she was pointing out that, you know, we have moved from giving people a nudge towards getting vaccination, perhaps telling them that you can't go out to eat or you can't go to a football match if you're not vaccinated, to telling them, you know, we will really interfere with your social well-being by taking away the tools or the aspects of your life that make it comfortable to live within society. So I think in that respect, it's very difficult to make a justification, even knowing the benefits of vaccination. It's difficult to make a justification for such an action from the government. And this goes back to what Melba said, those interventions that infringe on human rights in the long run tend to have negative effects on public health outcomes. For people in that situation, you may eventually coerce them into getting this particular vaccine, but in the long term, when it comes to implementation of public health measures beyond COVID, they might be very much less inclined to go along with government recommendations because of the distrust that's developed within those individuals towards the government that's providing mandates and recommendations. My original statement was that when making mandates, we should try to ensure that the goal of the mandate is to enhance the public good. And by the best way to do this would obviously be to get the public to buy into the intervention. We've talked about the need for proper communication on the disease, the intervention if it's a vaccine, and the benefits and how those can be weighed out against the risks. And also there's a need to have very localized participation within communities. I think there has been a lot of investment in infrastructure to deliver these vaccines to very far-flung parts of our geographies, but there has not been a corresponding investment into speaking to individuals within communities in a manner that they can understand the public health message. And I think we've seen this in Kenya and many parts of Eastern Africa, and I think it may be true also in Pakistan, where a lot of money is spent on the logistics without actually addressing localized issues that make hesitation at the local level prevalent. The last thing I'll say about that is, beyond COVID vaccines, throughout the history of vaccines and implementation in public health programs, hesitancy has always been an issue, whether we start from smallpox and coming all the way down to the latest available intervention. The points that have been made about addressing hesitancy have always been the majority of people are not vastly opposed to getting these interventions. They just need to have their individual concerns addressed, and addressing those concerns in a manner that individuals within normal communities can understand, and having those concerns addressed by members of their own community, so local health officials or local leaders, is probably the best way to do it. It's not probably the most fashionable way to do things, but it is generally found to be the most effective way of doing things. So going back to the question, I would go against a government recommendation to cause harm to individuals by blocking their SIM cards or other coercive measures that would eventually lead to poor public health outcomes. Thank you.
Can you allow me just to add to what Vincent and the rest have said, that indeed we are to look at lessons learned from handling this pandemic. I think we have failed in terms of communication, and I think it's inadvertent, but stigma has also been created around the disease, and that works as backwards against what we intend to do in terms of controlling the disease. And I agree with the rest of the panelists in saying that the only way, or rather the most effective way of earning confidence in an intervention in which you want the community to engage in is involvement. So enhanced communication and improving will work a long way towards improving community participation. But I think it's not too late. Those are things that can still be enhanced to ensure that we deal with the pandemic better in days to come. Thank you.
Okay, we have a question from Dr. Vakar online. Dr. Vakar, unmute yourself and ask your question, please.
My question is for Mr. Vincent. He was telling us that, in his opinion, it's not right to block the SIMs and all that. Let me just give you the example of Pakistan. Pakistan government, through the media, newspaper, tried everything through the cell phones, ringtones and all that, to aware the people about the consequences, what can happen to your family and all that. They made each and everything. So if it's not working, if people are not getting vaccinated, if blocking their SIM, I mean, what will happen if you block the SIM? I mean, for a week or for 5 days, what will happen eventually? I don't think so. It's a very big deal when you compare it with someone's life. So that's one point. And the second point, someone said in the chat box that the incoordination and all that. I will take the stage to really appreciate the NCOC, the way they work. 10 crore people have been vaccinated for at least one dose. That's a big achievement for a low middle income country. It's a big achievement. So hats off to NCOC. These are my two questions.
Okay, there's a question from Dr. Fasiha in the face-to-face. Yeah.
It's just a comment. What I feel about the whole topic is that I guess government has the mandate to make it a policy that everybody in the community should be vaccinated. We can have different thoughts on the way of mandating it, but as far as mandate is concerned, I think it lies with the government to make the public safe. Because when you're talking about COVID, as we see people dying in the clinics and doctors who are dealing with the patients see it every day, we know that how important and vital is for individuals' health and for the public health to get vaccinated. So I guess this is something that we all feel and know. The most important thing that I felt was that the policies and the laws that were implemented very irrationally and inappropriately. I can give you one example. When we're talking about universities and teaching institutes, the attendance was not given that importance. In the university that we work, was said that 50% in attendance is mandatory to sit in the exam. And even in the exam, if you have the symptoms, you should not come to the university or not come to the campus. But when you on the exam day, if you do not appear in the exam, if you have a symptom, you will fail and you have to repeat the whole year. So when you're making a policy and you are making people to go against the policy by making it very foolishly, I think that was the main issue. as far as the mandate was concerned. So I totally agree to the government being mandating the whole thing, because it was the way to go about in COVID, as far as I guess Pakistan is concerned. And we have seen all over the world, nobody was open to the vaccine. People in the West also resisted to get themselves vaccinated. So it's not an issue of a few countries. I guess this thing was unacceptable to all the world. So I guess it's a common problem of all of us.
Okay, I have my hand raised for a very long time, but my moderator is
Actually, I was going to come to you next, Dr. Amir. So,
okay.
So we teach
So
patience to our virtual participants. So
I actually had a question. Thank you. So my question was to Dr. Walter Jaoko, and of course the other participants from Africa. You have had experiences with dealing with the epidemic of HIV for a very, very long time. So you've had chances and opportunities to strengthen your public health response, as opposed to Pakistan, which has ignored HIV. We've had outbreaks and we've ignored them. We've had dengue and we've just lived through them or died through them. So we haven't really built up our public health services systems, other than in this particular pandemic, is, as Dr. Vakar was saying, that NCOC has come out of the blue and has actually 1 million vaccines a day is something that is phenomenal for Pakistan, a country like Pakistan. However, I wanted to ask, has your experience, I mean, Africa is not a monolith, but for instance, only in Kenya, has your experience in dealing for such a long time with HIV and all its aftermath helped you in some way in dealing with this particular pandemic?
Yeah, thanks, Prof. Amir. Unfortunately, I wish I could say yes, but it hasn't really. Probably because the epidemics, the HIV epidemic is a much slower epidemic. And unlike the COVID one, which cuts across all the populations, the HIV pandemic started in pockets of female sex workers and what we call the high-risk populations, which we know nowadays called key population. So unfortunately, I wish it had prepared us, but the response that we've had for COVID-19 shows that dealing with the HIV pandemic, epidemic did not actually prepare us for a pandemic. What I foresee is that in the event that we get another pandemic that is equivalent to the HIV pandemic, the experience that we have now had would be much useful than the experience that we got from the HIV epidemic. Okay. That is my view, and probably other people in the team might have a different view.
Okay, we have a question from Dr. Naima, and then we'll go to...
Can I just follow up on Jaoko's, please, before we move on from that? I agree with Professor Jaoko that there are a lot of lessons that we picked from, our years and decades of the HIV response. My feeling is that, and Prof, you will correct me if my feeling is off, I think there is an issue with utilization of evidence to inform laws and to inform policies. The way in which we generate information of what works and what does not work does not necessarily inform policymakers when they are trying to address issues. There are a lot of lessons that we would have quickly picked from HIV and used to inform how we've reacted to COVID from a country perspective, even from a regional perspective. But then I fail sometimes to understand the people who we trust with the responsibility of making decisions. Do they really know the use of evidence? And how does that evidence go towards informing the kinds of policies that they put in place? Because clearly from our response with COVID, particularly the use of coercive legal measures, we haven't learned a thing.
Okay, thank you, Melba. We'll take a question from Dr. Naima and then Dr. Stephen after that. So Dr. Naima.
I'm not getting any question. I just want to share my experience. When I took my mother for vaccination, and by the way, she herself was very reluctant to get vaccinated. And when she saw people around her getting infected or the sick conditions, she was willingly, okay, fine, took me there. And when we reached the area for vaccination, we found there were a great rush over there. And the doctor was there to ask me, Dr. Naima, please bring your mother tomorrow. I said, why? It's so rush over here. It will be tomorrow. There will not be any rush tomorrow because the date for this blocking of SIMS has been extended. So you will not find any person tomorrow for vaccination over here. So this is what experience I had, because unless there was a focus, so people were coming.
So whatever we may think from on an individual rights basis, this method worked in our part of the country. So Dr. Stephen, your question?
Yes, I do not have a question. I have a comment. My comment is the fact that we did have some advantages that we had learned from previous experiences. The first one was on the rollout of the vaccines, because Kenya already had a national vaccination program for decades, which had developed a network of systems of storage, had trained nurses and other healthcare workers on handling vaccines. We had established means of retaining the cold chain. And this was very helpful in the rollout for the vaccines, in that when the vaccines were first came in, it went into the network. The rollout was through the network of established national childhood vaccinations that was already in place. They had storage place, and they had means to transport, and they had personnel at least who were able to give the vaccines without much training. And so with a short training, the rollout could take place. The other, from what we had established within the HIV response came as an advantage when COVID went into our countries, into the rural areas, because those rural areas, because of the HIV response network, had community health workers that had been trained, that had been used within the HIV response network. And these community health workers and this network was effective in terms of, one, case tracing. And by the time that it had gone into the rural areas, they had already established home care, home-based care for those who are not critical. And the community health workers and the network that had been developed was useful in putting this into place. So I would say that the HIV response was advantageous in when COVID went into the rural areas, that the network that had been established did help with the home-based care program within the rural areas, and also in the vaccine rollout. Thank you.
Okay, thank you. Any, yes, James, do you have a comment?
Yes, with your permission.
Yes, please.
I agree with Professor Mukhudhia's comment that over the years, the systems, at least on the Kenyan side, were in place, and the response would ride upon those systems. And as I had alluded earlier, I think the mistake we repeated was creating stigma around the disease. So when HIV came into Kenya, there were big billboards that were put of people who are very thin and people you want to avoid. And, you know, when COVID came, when someone died, you know, they would be delivered at home like a piece of luggage, straight into the grave with people who are, you know, donned in white, you know, and so, and people who had there was any suspicion of exposure were confined into these quarantine sites. And so the perception against disease was something that made it something difficult to fight with. But I think I'd applaud the government in terms of, or rather the health department response in terms of trying to communicate in terms of what the picture is, what you need to do to prevent transmission even to your parents, to your loved ones, stay at home, wash your hands, put on masks, and so on. So I feel like it is a mixed bag. On the Kenyan side, there are things that worked well, and there are things that we repeated as mistakes from the HIV pandemic. Thank you.
Okay, thank you very much. Dr. Asma, I think you have one final comment and then a question.
Well, a small question for the panelist. Thinking, we have discussed the mandatory thing and the strict thing on our population. So what do you think about the Chinese response to this pandemic with 100% lockdown and everything?
Interesting question, Dr. Walter or Dr. James, would you like to take that up?
Sorry, I didn't get the question properly. I think
the question was
there's a
regarding Chinese measures being taken to control the pandemic.
Yeah, I think I alluded to this earlier on. I think the Chinese measures can only be implemented in a country that does not have a lot of freedom in terms of democratic rights and so on. I do not see those kind of measures being implemented in a country like Kenya, because we have a very robust court system, as maybe Melba will agree with. Anybody can go to court and challenge those kind of measures that are seen to be so draconian. So I think it is not possible, in my opinion, to implement those kind of measures in a freely democratic country. China is a very unique country that they can be able to do that. Whatever the government says, it's what goes without much opposition, but I don't see that happening. I think there's a lot of, it goes against a lot of the things that we've been discussing this today with regard to, is it proportionate? Because some of the things that they did was even stopping people from going to supermarkets to buy food. You'd think that it's really extreme. And some of the things that we discussed today about the proportionality of the measures that are taken and in the presence of alternative ways of doing it that is not so draconian would make it not ethical, in my view. Thank you.
Okay, thank you, Walter. Over to you, Dr. Amir, for your concluding remarks.
So thank you, panelists. I think this was a very, very good ending culmination of a 3-day event that we were having, this workshop, hybrid workshop. And I think our panelists, including our primary speaker, Dr. Walter Jaoko, set the stage, and our commentator, Dr. Vincent, elaborated on what he said. And then, of course, the 4 panelists, Natasha, James, Melba, so did I miss anyone? So James, Melba, and Natasha, yes, did a good job in raising all these challenges. Now, one aspect of this entire pandemic business has been that it is actually a challenges in evolution. So what we had initially thought of, and I think we did a good job in thinking ahead about the vaccine passports, etc. Now I have my vaccine passport in my phone. every little app which says so, but we were discussing the ethics of that. Now I am using that. We were just last couple of weeks ago discussing the ethics of the booster dose. We don't call it the booster in Pakistan. We call it an additional dose or a re-vaccination. But we are at the point of getting that, since and we are justifying that from the point of view of travel requirements, etc. So our challenges keep increasing as the pandemic increases and subsides and increases and subsides, and we are on the trough of our fourth wave, and we are hoping that there will be no fifth wave, or at least it will be subdued. But the challenge will keep coming on. So these kinds of interactions for all of us are very important, because we keep learning from each other's experiences. The experiences from our point of view as a low middle income country, and learning from our colleagues in Africa. Some of them have done very well. Some of them in general have not, because of the paucity of vaccines and the unjust system that prevails across, and what we've been talking about. So these interactions are extremely important to keep going on, and we will try and keep up with our colleagues in Kenya and other parts of the world to keep coming up with such events, and with the collaboration that is going on with our various partners, including the WHO and our CKPTI program, etc. We are in a good position, I think, to be able to offer these periodically. So I would like to say thank you and goodbye to our webinar participants, the participants for the webinar that had joined us. But I would like our 13 participants online to please stay on in the meeting while we say goodbye to the others. The physical participants in the hall, as well as the ones online who are registered for our workshop, should still stay on for another 5 minutes, so that we can have a good photograph, virtual plus physical, with you somehow or the other. My colleague Farid has figured out how he will do that. So goodbye to everybody else, and thank you very much, my panelists, and hope to see you again soon. And students, please stay.
Thank you. Thank you very much. Bye-bye.
Bye.
Thank you. Bye-bye.
Students, I hope, are still here. Some of us, yes, they are there. So if you could have the larger screen. And Dr. Bukusi, I'm hoping that you are among our attendees right now.
Yes, I am. I haven't gone anywhere. I'm right here.
Fantastic. Yep. Great. So, Dr. Bukusi, the 22nd of October has almost passed, and our prayers continue for our mutual interests. But before we do that, I mean, we continue to do that. This was the first collaborative webinar that a workshop that we've actually done in a series of 3 that are coming up. Some of you, all of you are aware of them, I hope, but some of you may also have actually applied for that. And we are hoping for that. But the public health focus of this particular webinar, the other ones are of course different. The public health focus of this workshop is also something that is going to be continued. And we are hoping to have more workshops of this nature with different dimensions, particularly for research ethics, and now also for clinical ethics. Because while the public health has overtaken our imagination and our physical and mental well-being, we are also still confronted with a lot of clinical ethical issues that Dr. Bushra keeps saying, because she works with patients. So she keeps saying that, and we have to have one of our future workshops will actually be on clinical ethics. We are hoping that it will all be physical, and possibly also physical as well as virtual, if the hybrid seems to be working or not. We still don't know whether hybrid is working or not, because this list of people have not responded to our no, of course. So we are holding their certificates. Yeah. So anyway, so what I wanted was to thank all of you for your patience, for keeping your videos on all the time. It is very difficult to stay in front of a screen with the switch on and look very engaged, even though glancing at WhatsApp now and then is always a good distraction revival. But we over here, of course, physical is very, very different because you can walk around, have tea, talk to people, etc. So we've tried to mix that together, and we'll find out whether how well that. And we also want to understand how the content, our content worked, and how we as facilitators and were able to actually handle the content. So before the photograph, I would like Dr. Bukusi to say a few words.
Thank you very much, Dr. Amir. I think I will just echo your words and thank everybody for the interest, the willingness, the availability to be part of this workshop. I hope that there is a lot that you have learned. I have personally learned a lot from the interactions and from listening. And I hope beyond learning a lot that we'll be able to share what we've learned with others to improve their learning as well. And that even more that we can influence whatever aspect we're able to influence to make people's lives better as a result of what we've learned, that we will put it into practice. Thank you very much, Dr. Amir, and I'm handing over back to you.
Thank you, Dr. Bukusi. And Dr. Farid is going to somehow, yeah, he needs a couple of more minutes to figure out how to take a picture of virtual and physical together. I have no clue. But one thing that we've learned with the physical as well as the virtual is that it works only if everybody is more committed in the workshop. A physical workshop is okay. I mean, people doze off. If somebody dozes off, and I come up to Asma and stand next to her, she'll wake up. But if somebody dozes off online, it becomes a challenge. And of course, what Dr. Bukusi has been pointing out, that if more than one people are talking at the same time, it becomes incomprehensible in a physical environment also, but still you can make out. But certainly for those online, if it becomes even more difficult. So we have to learn the etiquette also. Okay, so can we have a consensus on the picture? Yeah. Everybody stands over there. People go and stand next to the slide. Yeah. Great. Excellent. Yeah. And keep your masks on. So enforcing public health measures on public health practitioners is a very difficult thing. Mustafa Yasab, can you open your camera?
Cornelius also needs to go back on camera.
So folks, thank you very much. This is done. We'll share it with everyone after we've received your feedback.
Thank you, all of you. Thank you very much.
Bye-bye.
Thank you.
Thank you, Dr. Mukherjee. Thank you very much.
Bye.